The chief complaint. Ms. Brown is a 58-year-old woman with diabetes, hypertension, and hyperlipidemia who presents with shortness of breath for 3 weeks. Ms. Brown reports being in her usual state of average health until 3 weeks ago, at which time she developed a gradual onset of shortness of breath while walking up stairs and completing some routine housework. Over the next 3 weeks, her shortness of breath gradually worsened such that its onset required less and less exertion. During this time, she also began experiencing trouble breathing while lying down at night, prompting her to begin sleeping on 2 to 3 pillows instead of her usual 1. Finally, on the day of admission, she abruptly woke at 2 a.m. with severe breathing difficulties and was noted by her husband to be slightly blue, who then immediately called 911. She currently describes her shortness of breath as constant and severe. She describes it kind of in her own words as, quote, "I can't get enough oxygen in fast enough." And she's most concerned that she may be having a heart attack because that's what her father passed away from at about approximately the same age as herself. Her other cardiovascular risk factors include prior smoking. Relevant review of systems is notable for ankle swelling and a non-productive cough for the past 3 weeks, but she otherwise denies chest pain, palpitations, lightheadedness, fever, changes in weight, or hemoptysis. She has had no sick contacts or unusual travel. Her past medical history is notable for the aforementioned hypertension, diabetes, and hyperlipidemia, all of which were diagnosed 10 years ago and all of which she's getting treatment for currently. She has a surgical history of an appendectomy in 1977, a cholecystectomy in 1998, and a hysterectomy in 2008 for dysfunctional uterine bleeding. Psychiatric history is notable for several episodes of depression, but no reported history of psychiatric admissions or suicidal ideation. Her medications at home include HCTZ 25 milligrams daily, lisinopril 20 milligrams BID, metformin 850 TID, glyburide 10 BID, simvastatin 40 daily, and aspirin 81 milligrams daily. Her compliance is reported to be very good. She has an allergy to penicillin, which causes a rash, and radiocontrast, which causes urticaria. Social history is notable for 30-pack year smoking history. She quit in 2006. She consumes 1 to 2 alcoholic drinks per day. She is currently married and works as an administrative assistant. Her family history is notable for her father, who, as I mentioned, had an MI when he was 54, and he died at 69 from a stroke. Aside from what was reported in the HPI, a complete review of systems was otherwise unremarkable. On physical exam, she is overweight and appears in modest respiratory discomfort. Her vitals at the time of my exam showed a pulse of 100. She had a respiratory rate of 24, blood pressure of 130/105, and a temperature of 37.1. Focusing on just the pertinent positives and negatives of her exam, her pulmonary exam revealed bibasilar crackles, left greater than right, with no wheezing. Her cardiac exam was notable for a regular rhythm, a PMI in the 5th intercostal space in the anterior axillary line, a normal S1 and S2, with a 3 out of 6 systolic crescendo-decrescendo murmur, best heard at the 2nd right intercostal space with radiation to the carotids. Her JVP was 8 centimeters. Abdominal exam was normal. Extremities with mild bilateral and symmetric pitting edema to the ankles, without calf tenderness or erythema. A thorough neural exam was notable only for 1+ biceps and triceps reflexes bilaterally. Regarding her labs, her chemistry panel was notable for a BUN of 24 and creatinine of 1.1. CBC had a white count of 9 and a hemoglobin of 12. Her troponin is still pending at this time. UA showed only 2+ protein and 2+ glucose. Her chest X-ray revealed cardiomegaly, a cephalization of vascular markings, subtle curly B lines, and a small right pleural effusion. Her EKG showed sinus tach and occasional PVCs. She had a little bit of left axis deviation, and LVH was suggested by conventional voltage criteria in the precordial leads, but she had no ST or T changes of any kind on any of the leads. In the ER, prior to my examination, she had already received oxygen therapy via face mask, sublingual nitroglycerin, 325 of aspirin, and 40 milligrams of IV furosemide because the ER was concerned about pulmonary edema and possible acute coronary syndrome. Afterwards, after she received this treatment, she reported feeling slightly improved. So in summary, Ms. Brown is a 58-year-old woman with multiple cardiovascular risk factors with a subacute presentation of progressive dyspnea, mild symmetric lower extremity edema, and a non-productive cough. She has objective evidence of modest volume overload and LVH, along with a murmur consistent with aortic stenosis.